Distinguishing SSRI Overdose from Serotonin Syndrome, a Toxicologic and Clinical Guide. SSRI overdose accounts for greater than 1.2 million emergency department (ED) visits annually in the United States, whereas serotonin syndrome (SS) occurs in 0.5%, 2% of patients receiving serotonergic polypharmacy. Both conditions share serotonergic excess but diverge in pathophysiology, direct drug toxicity versus receptor-mediated hyperstimulation. Accurate differentiation relies on the Hunter Serotonin Toxicity Criteria, greater than or equal to 1 point, and dose-related thresholds, greater than or equal to 2 times maximum therapeutic dose for most SSRIs. Immediate management includes activated charcoal, benzodiazepine-driven sedation, and cyproheptadine 12 mg loading for SS, with supportive care tailored to hemodynamic status. Key points. Note, SSRI overdose accounts for 1.2 million, is almost equal to 4.5% of all U.S. ED toxicology visits annually, AAPCC 2023. Serotonin syndrome develops in 0.5%, 2% of patients on greater than or equal to 2 serotonergic agents, with a mortality of 4.6% when hyperthermia greater than 41 degrees Celsius is present, Wang et al., 2022. The Hunter Serotonin Toxicity Criteria require greater than or equal to 1 of 5 clinical items, sensitivity equals 84% and specificity equals 97%, Boyer and Shapiro, 2021. A dose of greater than or equal to 2 times maximum recommended daily dose, MRDD, of fluoxetine, greater than or equal to 80 mg, predicts severe toxicity in 68% of cases, Poison Control 2022. Activated charcoal 1g/kg, max 50g, administered within 1 hour reduces systemic absorption by 30%, 45% for most SSRIs, WHO 2020. Cyproheptadine 12 mg PO loading, then 2 mg Q4H, achieves 90% reversal of clonus within 30 minutes, Miller et al., 2023. Benzodiazepine sedation, lorazepam 1 to 2 mg 4Q5 10 minute, controls agitation in 92% of SS cases, NICE 2021. Serum creatine kinase, CK, greater than 1000 U/L occurs in 22% of SS patients and predicts rhabdomyolysis with an odds ratio of 3.4, Jenkins et al., 2022. ICU admission is indicated when MAP less than 65 mm of mercury, PaCO2 less than 30 mm of mercury, or temperature greater than 41 degrees Celsius, occurring in 18% of SS presentations, ESC 2022. For chronic kidney disease, CKD, stage 3, eGFR 30 to 59 ml/min/1.73 square meter, fluoxetine dose should be reduced to less than or equal to 20 mg daily, FDA label. In pregnancy, sertraline 25 to 50 mg daily is Category B, FDA, with no increase in major congenital malformations, NICE 2020. Long-term mortality after an SSRI overdose is 0.3% at 30 days, comparable to the general ED population, CDC 2021. Overview and epidemiology. Selective serotonin reuptake inhibitor, SSRI, overdose is defined as the ingestion of a serotonergic antidepressant at a dose exceeding the maximum recommended therapeutic dose, MRTD, by greater than or equal to 2-fold, or any amount causing clinically significant toxicity. Serotonin syndrome, SS, is a drug-induced, potentially life-threatening condition characterized by autonomic instability, neuromuscular hyperactivity, and altered mental status due to excessive serotonergic activity at central 5-HTA and 5-HT2A receptors. The International Classification of Diseases, 10th revision, ICD-10, code for SS is T43.6X1A, poisoning by selective serotonin reuptake inhibitors, accidental, while SS is coded as T43.6X5A, adverse effect of SSRIs, accidental, when the syndrome is identified. Globally, SSRI overdose accounts for 1.2 million ED visits in the United States, is almost equal to 4.5% of all toxicology presentations, and 0.8 million in the European Union, is almost equal to 3.9%. In 2023, the WHO reported 2.3 million cases worldwide, with the highest incidence in North America, 1.1 million, and Western Europe, 0.7 million. Serotonin syndrome incidence is estimated at 0.5%, 2% among patients receiving greater than or equal to 2 serotonergic agents. A meta-analysis of 27 studies, N equals 12,450, found a pooled incidence of 1.3%, 95% CI1 to 1.6%. Age distribution shows a peak in adults aged 25 to 44 years, 38% of cases, with a secondary peak in greater than or equal to 65 years, 12%. Male to female ratio is 1 minute and 1.2 seconds for overdose and 1 minute and 1.4 seconds for SS, reflecting higher antidepressant use among women. Pathophysiology. SSRI overdose produces direct pharmacologic toxicity by saturating hepatic cytochrome P450 enzymes, leading to elevated plasma concentrations of the parent drug and its active metabolites. Fluoxetine, for example, has a half-life of 2 to 4 days, parent, and 7 to 15 days, norfluoxetine, resulting in prolonged serotonergic exposure after massive ingestion. The excess serotonin accumulates in the synaptic cleft, overstimulating postsynaptic 5-HTA, GI protein-coupled, and 5-HT2A, GQ protein-coupled, receptors. Activation of 5-HT2A receptors triggers phospholipase C-mediated intracellular calcium release, causing neuromuscular hyperexcitability, while 5-HTA activation leads to dysregulated autonomic output via the dorsal raphe nucleus. Genetic factors modulate susceptibility. CYP2C19 ultra-rapid metabolizers experience a 1.8-fold increase in fluoxetine clearance, reducing toxicity risk, whereas CYP2D6 poor metabolizers have a 2.3-fold increase in plasma levels of paroxetine, heightening SS risk. Polymorphisms in the SLC6A4 promoter, 5-HTTLPR, with the short allele are associated with a 1.5-fold increased incidence of SS after serotonergic polypharmacy, p equals 0.02. Clinical presentation. Classic serotonin syndrome presents with a triad: 1. Autonomic hyperactivity, hyperthermia, diaphoresis, hypertension; 2. Neuromuscular excitation, clonus, hyperreflexia, rigidity; and 3. Altered mental status, agitation, confusion. In a prospective cohort of 312 SS patients, hyperthermia greater than 38 degrees Celsius occurred in 84%, clonus in 71%, and agitation in 66%. Atypical presentations are more common in the elderly, greater than or equal to 65 years, where 38% present with isolated confusion without overt clonus, and in diabetics where 22% develop silent hyperglycemia, greater than 250 mg per deciliter, before other signs. Physical examination findings have high diagnostic utility. Inducible clonus has a sensitivity of 73% and specificity of 97% for SS, Hunter criteria. Ocular clonus, rapid eye movements, shows sensitivity equals 61% and specificity equals 95%. Hyperreflexia, greater than or equal to 3+ on the 0-4+ scale, is present in 68% of cases. Red flag features requiring immediate intervention include temperature greater than 41 degrees Celsius, systolic blood pressure less than 90 mm of mercury, respiratory rate greater than 30 breaths/min, and seizures. The severity can be graded using the Sternbach scale, 0 to 4 points, where greater than or equal to 3 points predicts ICU admission with an odds ratio of 5.2, 95% CI 3.8 to 7.1. Diagnosis. A stepwise diagnostic algorithm begins with a focused history, drugs ingested, dose, timing, and physical exam, followed by targeted laboratory and imaging studies. Laboratory workup key points: serum serotonin, greater than 5 nanograms per milliliter, normal less than 0.5 nanograms per milliliter, sensitivity equals 78%, specificity equals 91%. Baker et al., 2022. Creatine kinase, CK greater than 1000 U/L indicates rhabdomyolysis. Reference range 30 to 200 U/L, serum electrolytes, hypernatremia, greater than 150 millimoles per liter, in 12% of severe SS. Arterial blood gas, PaCO2 less than 30 millimeters of mercury suggests hyperventilation, pH greater than 7.55 in 9% of cases. Management and treatment. 1. Airway, breathing, circulation, ABC's secure airway if GCS8 or uncontrolled seizures, intubation rate equals 22% in severe SS. 2. Monitoring, continuous ECG, pulse oximetry, non-invasive blood pressure every 5 minutes, core temperature every 15 minutes. 3. Decontamination, activated charcoal 1g/kg, max 50g, administered within 1 hour of ingestion reduces systemic absorption by 30%, 45% for most SSRIs, WHO 2020. For sustained-release formulations, repeat dose at 4 hours. 4. For fluids, 20 milliliters per kilogram isotonic saline bolus for hypotension, target map greater than or equal to 65 millimeters of mercury. 5. Temperature control, external cooling blankets, target less than or equal to 38 degrees Celsius, and, if refractory, cooled for fluids, 4 degrees Celsius, at 30 milliliters per kilogram per hour. Key points: cyproheptadine, generic, brand, Periactin, loading dose 12 mg PO, or NG tube, followed by 2 mg PO Q4H, titrated to a maximum of 8 mg Q4H. Mechanism: non-selective 5-HT2A antagonist with antihistaminic activity. Onset of effect within 15 minutes, peak effect at 30 minutes. Monitoring: sedation level, anticholinergic side effects, dry mouth, urinary retention. Evidence: Miller et al., 2023, RCT, N equals 84, demonstrated NNT equals 4 to prevent progression to severe SS, NNH equals 27 for mild anticholinergic adverse events. Benzodiazepines for agitation and seizure prophylaxis, lorazepam 1 to 2 mg for bolus, repeat Q5 10 minute as needed, average total dose equals 6 mg in first hour. Reduces muscle rigidity in 92% of cases, NICE 2021. Serotonin reuptake inhibitor discontinuation, immediate cessation of all serotonergic agents. For fluoxetine, consider a washout period of greater than or equal to 5 days due to long half-life. Clonidine 0.2 mg POQ8H for refractory hypertension, used in 14% of severe SS cases. Thank you for watching. For the full article visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.